Good morning, everyone. It's my pleasure to welcome you all to monthly Speciality Day of Ceylon College of Physicians. I'm Dr. Duminda Munidasa, the president of the Ceylon College of Physicians. And this month, Specialty Day is on nephrology. We are doing it in collaboration with Sri Lanka Society for Nephrology. And I would like to warmly welcome, first of all, my co-chair, Dr. Anuraheva Giganagi, the immediate past president of the Sri Lanka Society for Nephrology, and also our esteemed resource personnel, Professor Magdi Yaqub will be joining us from UK. Very warm welcome to you, Professor Yaqub, for joining us early morning from UK. And then we have Professor Vijay Vikrama and Dr. A.W.M. Vasil, the consultant from Kandy, and Dr. K.K.A. Sandeep, the senior registrar for the last session. So it's my pleasure to invite my co-chair, Dr. Anuraheva Gigani, to introduce our first speaker, Professor Magdi Yaqub. Over to Anurah.
Good morning. It's my pleasure to introduce our first speaker, Professor Magdi Yaqub. Professor Yaqub is a professor of nephrology within Center of Translational Medicine and Therapeutics at the William Harvey Research Institute at Queen Mary College of University of London. He is the academic director of the Department of Renal Medicine, Transplantation and Diabetic Kidney Disease at the Barts Health NHS Trust, UK. He graduated in medicine in 1982 and later obtained his MD and PhD. He joined the Royal London Hospital as a consultant in January 1996 and was awarded Personal Chair in Nephrology by Queen Mary's College, University of London in 2001. He is a recipient of several awards for an exemplary research career. Professor Yaqub is an internationally recognized expert in nephrology and transplant medicine in areas of cardiovascular diseases, of uremia, including hypertension, accelerated aging, diabetic kidney disease, renal anemia, renal bone disease, progression of chronic kidney disease, and mediators of acute kidney injury. He has visiting professorships to several international universities. Having published over 400 heavily cited research papers, his current H index stands at 62. Today, he will be talking to us on uremic cardiovascular diseases, a futuristic view. Over to you, Professor Yaqub. And I should tell you that the additional time that you wanted, 10 minutes, was allotted to you. Thank you.
Right. Thank you very much for your kind introduction. And first of all, thank you very much for inviting me. I was told that there are many trainees in your audience, and they are very close to my heart. Wherever there are trainees, I would be the first one to go and connect with them. So this talk is for the junior faculty, as well as those who are in the audience and who are taking their first steps towards becoming consultants. I'm directing most of my talk to them, and it is my personal view what the medicine will look like in years to come. Maybe I won't be around then, but I am 100% that if 10 to 20% of what we do, what we are researching today, was to become a bedside medicine procedures, the sort of things our trainees will be doing in future will be completely different from what we do today. So it's also a sort of a psyche preparation for you, what lies ahead. With that, I'll start with my very favorite quote. Is Benjamin Franklin. He was, I think, the godfather of modern United States of America. He was the drafter of their Treaty of Independence. And he was a polymath. He knew everything. He was a scientist. He was a theologian. He did everything. And he gave this quote, which I repeat: tell me and I forget, teach me and I may remember, involve me and I learned. For me, it was one of the best quotes I read when I was growing up, like you guys, and I interpreted involve me and I learned was for me researching. So I researched almost on every aspect of nephrology as well as internal medicine. And that helped me remember things even in my old age. I slightly changed that quote and put my name to that quote, which says now that tell me and I forget, teach me and I may remember, tell me a story and I'll remember, involve me and I learn. The other thing which I learned in my career was that if I have trainees like you with me who are working with me, I've learned to trust them fully. And whenever I've trusted them, they have always delivered. So that is my few addition to a famous quote of Benjamin Franklin. And as we progress in my talk, I may interrupt my talk by telling you a few stories which may or may not be relevant for you guys, but this is how you possibly will remember some of the things which I'm going to share with you. At the moment, we do a lot of clinical trials. I think if you open any journals, you will see one randomized control trial on every subject. Mostly they are sponsored by the commercial pharmaceutical companies, where they try to push their drug onto the formularies. Randomized control trials, as we all know, are the gold standards, but there are many other forms of randomized control trials which we now are doing, and these trials are now on trial themselves. The people like myself and many others, we are very critically analyzing these trials to see whether these trials basically are fit for purpose for the future workforce. What happens with these clinical trials is that there is a panel of experts who meet and they draw guidelines. And I personally believe, and I've always believed, that if you want to do a precision medicine or personalized therapy, then guidelines is the biggest enemy of that objective. Guidelines promote one-size-fits-all clinical practice. We are given a set of drugs and we are told even in which order to use them. And that is now being recognized by people who believe in precision medicine, that guidelines are now being interpreted as biblical statements and being practiced by our workforce. And I'm not saying that the guidelines should not be there, but they should not be practiced like biblical statement. They should be interpreted as a recommendation, and we should be using those recommendations which is appropriate for the patient who is sitting in front of you. So my statement for guidelines is that guidelines is for the whole population. Physician is for the patient who is sitting in front of him. So you are responsible for that particular patient who is sitting in front of you, and that cannot be, you cannot say that that person would fit in the guidelines which we have drafted. Guidelines are not comprehensive enough to cater for everyone. One of the things which I'd like to introduce to you guys is what I passionately believe, to see how robust a clinical trial is. So when you do or read the clinical trials from today onwards, use this index, we call it fragility index. What is fragility index, which I always use? Fragility index is basically measures the robustness of the clinical trial. And what it means that if you were to take the number of events in your placebo arm or an intervention arm, and you demonstrate that your intervention arm has been beneficial by reducing an event, whatever that event is, which could be event A, by fragility index, you can determine how many events from that intervention would become negative for that trial to be negative. So it gives you the number of events needed to convert that trial into being negative. And if the number of events which are required to turn that clinical trials into negative is less than the number of dropouts, which is by that mean that the patient dropped out from the clinical trial for whatever reason, then one should take that for that it is at best mild to moderate benefit. Let apply to this dogmatic guideline advice which we push in our guidelines, that ACE inhibitors or ARBs are the best thing ever happened to renal medicine over the last 3 decades. And has those trials which we did stood up the test of fragility index? So this is the sum up of that. You can see that there are a lot of trials done, and over 80,000 patients are included in this analysis. Just want to tell you, 80,000 sounds a lot, but at the moment there are 850 million people with CKD. If you were to look at that, this 80,000 looks a minuscule sample of that 850 million people. Second thing, in these trials, I looked for that how many patients from the area where I'm talking to, which is Sri Lanka, India, even China, Bangladesh, Pakistan, Nepal, how many patients in this 80,000 patients were from those regions? And guess what? Not a single patient came from those countries. So I'm just giving you what the current state of play is. We use ACE inhibitors, we use ARBs, but does this strategy stand up to the test of fragility index? If you were to apply the fragility index parameters and see how robust these clinical trials have been, you can see that there were some clinical trials which was done as primarily in chronic kidney disease patients, and there were some clinical trials which were done where the chronic kidney disease was a secondary endpoint. So it was done mainly for the heart failure or other conditions, and chronic kidney disease happened to be a secondary endpoint. And you can see that in both primary and secondary, the CKD, you just needed to have 5.5 events to become negative for that trial to lose their significance. And that would be regarded as mild, at best, moderate benefit of ACE and ARBs. And that's what we have been doing based on this evidence, which may even not be applicable. I hope it will be, or it may be even more potent, but we have never done clinical trials, particularly including patients from the region which I just now mentioned. But forgetting that, even for the Western population, if you look at it now today using fragility index, for the last 30 years, we have been practicing clinical medicine for ACE and ARBs, thinking that ACE and ARBs is the answer to everything in chronic kidney disease. And to me, that stopped the discovery of new medications, because that gives us a false sense of security that we have got the best drug on this planet to stop progression of kidney disease. But we forgot that even using these medicines, there is still a very residual effect, and many people still progress to end-stage renal disease despite using those medications. Let's test in 2023, from what I told you, that if ACE inhibitors and ARBs were that good, then they would be the best drugs for very advanced stages of chronic kidney disease, which is stage 4 and stage 5. So I would imagine that if it is biblical that we cannot go without these medications, if we were to stop those medications, then our patients who are stage 4 and 5, who have taken many steps towards end-stage renal disease, will come to harm. And this was the trial done from United Kingdom recently, where more than 400 patients were randomized. Half of them stopped their ACE inhibitors and were replaced with another antihypertensive, and another half, they continued with the same medication, which is ARBs, ACE or ARBs, and see what happened. And as you can see, that there was no difference over the 2 years period of those patients who either stayed on ACE or ARBs, or those who replaced it with some other medications, which goes to show, and I'm interpreting it completely differently, but I'm interpreting this data to my argument that if stopping ACE and ARBs would have, was going to cause harm, we would have picked it up. In progression of renal disease or in heart outcome, there was no difference between the two groups. So if you have got a patient, you are worried about hyperkalemia or some other issues, and you've got a GFR of 15, you can very safely stop ACE inhibitors and replace it with any other agent. Or you have got a person where you want to try ACE inhibitors and he's not on it, you can still use it. For antihypertensive effect, it would not, in my opinion, any additional benefit when it comes to a renoprotective specific effect. So how to get around all this? That we do all these randomized controlled trial, which involves thousands of patients, and then you need only 5 to 10 events to turn to other side, and this trial becomes negative. But we view it because the p-value was 0.0001, that becomes a big trial, and we all start practicing it, which may not be relevant for the population which you are looking after your patients. And the way to do that would be the futuristic view. I am 100% that come 10 years or 15 years time, there won't be any randomized controlled trial. It would be replaced by n equal to 1 clinical trial. The patient which you have got in front of you would be his own control, and we will be using multiple medication in random order in that particular patient. And that person would be a trial of his own, where we'll be using multiple drugs and realize which one of those drugs would be useful for that particular patient. It would be definitely possible in light of what's happening with omics-based strategies, as well as AI-based drug matching. This is already happening to some extent in oncology, where they do the omics analysis of the whole tumor, and then they ask the AI to match those omic data with the drug which will be appropriate for that particular tumor. So you then now walk away from one size fits all. You just give that combination of drug to that person which is appropriate for that stage of tumor. Whether it applies to us, let's go into cardiac. This is the personal data from our own unit, where we used to do post-mortem on every death, or if we couldn't do it, 4 or 5 senior physicians will sit and assign the cause of death. We had over 5,000 patients went through this over the 10 years period. And you could see, like every other unit, we said that cardiovascular is the commonest cause of death in patients who are either on dialysis or transplantation. And if it is a cardiovascular, we did a lot of clinical trials, which we were part of, and you can see that everything which worked in general population, none of them worked in renal failure patients. And after so many negative trials, we got one positive trial, which is a SHARP trial, which we were part of, which was basically lowering LDL cholesterol with simvastatin and ezetimibe, reduced the revascularization rates in patients with end-stage renal disease or CKD. It was positive because it included only 1/3 of the patients were end-stage. Remaining patients were CKD, and if you look at the data, it was beneficial in patients with CKD rather than end-stage renal disease. However, when you look at the mortality data, it was negative. Despite recruiting over 7,000 patients, we were not able to show any benefit on the mortality. So most of the studies which we did for cardiovascular disease, which were focused on atherosclerosis, were negative. And the reason was this: we knew it all along that they will be negative, because we believe that most of the cardiovascular disease which we see in CKD as well as end-stage renal disease is myocardial disease. So you can't expect statin to work in myocardial disease. Yes, statin would affect the atherosclerotic component, but that is very tiny compared to the myocardial disease from our own data. And we all know that when the patient is taking its progression from early stages to end-stage renal disease, myocardial disease is very prevalent. Only 15% of the patient would have normal LV, which is now not true, because we know that those even have got diastolic dysfunction. So if you were to look at the patient who is just about to start dialysis, almost every patient who is about to start dialysis will have some form of myocardial disease, which starts with diastolic dysfunction, LVH, eccentric LVH, and systolic dysfunction. That is the way it progresses. And reason underneath was that over 90% of the patients are anemic when they start dialysis, and over 90% of the patients have got hypertension. And these are the two main drivers for LVH. Is it true that these are the only two drivers which cause, and we question that yes, they may be playing a role, a huge role, but can you get LVH in uremia without hypertension and anemia? And for that, we created an animal model which had only mild chronic kidney disease, which would be equivalent to at best stage 1 or stage 2 CKD. Took a lot of effort to create those animal models. And you can see that they were normotensive, uremic, non-anemic, and at that early stage, they were developing LVH. So there is something happening even very early stage of uremia when they've got no hypertension anemia, that they are developing LVH, and not only mild, but very marked LVH. And that what we thought that was something to do with compensation of myocardium to whatever the uremic toxins there are in the circulation. The second thing which we did was that we isolated myocardium from these uremic animals and controls, and we were able to demonstrate for the first time that the calcium level, both during diastole or during systole, was significantly higher in the uremic myocardial cells as compared to controls. You can see their marked increase in cytosolic calcium. We went a further step forward, and we looked at what happens to the calcium transit. So when we electrically stimulated myocardial cells, you could see that the time to peak and the peak of both calcium in both controls and urine was the same. But it took longer time for the uremic myocardium to normalize their calcium to baseline. So there was more calcium in the myocardium throughout the cardiac cycle. That would reflect into being a more contractile property of myocardial cells. And that's what we demonstrated in vivo Langendorf preparation of myocardial hearts compared to controls. You can see for every increase in the left ventricular volume on Langendorf preparation. Langendorf is a preparation where you've got a beating heart ex vivo, and you can do pressure measurements as well as volume measurements. It's a very neat technique which is up and running in my lab for the last 30 years. So if you increase the volume, like a Frank Sterling curve, you expect more contraction. That's what happens. And this is what the Frank Sterling curve will show in normal. But you can see in uremic animals, because they've got high calcium, you would have expected them to contract more as compared to controls. So that was phenotypically proven. The person who did that PhD was Professor Alistair Chesser. He's now he was my student. He's now a professor himself. Of the many PhD students I had, many have now gone on to become professors, which is it's a matter of pride for me. And Alistair Chesser is also the chief medical officer of Bart Trust, where I work. So we explored what is happening in the myocardium at the signaling level. I won't bore you with all these pathways, but I just want to highlight that the first thing which we hinged on was calcineurin. If you put a little ligature around the aorta and create coarctation of aorta in an animal model, they get LVH. And when we block calcineurin with the calcineurin inhibitors, they did not get LVH. So it was very, very convincing that calcineurin somewhere along the line is playing a role in the early stages of LVH. However, that excitement abated because if you were to leave calcineurin inhibitor 2 weeks after LVH has happened, there was no benefit, because calcineurin triggered the pathways which became redundant for itself, but they had triggered the pathway which has gone further down. And that is what I was alluding to, that even in uremic myocardium, the strategies which we will use will be different based on omics technology. So if you have got LVH, which is in early stage, maybe something like calcineurin may work. But if it is a later stage of LVH, that strategy which was working in the early stages would not work. So we will have to choose different medication. And that's what your future looks like to me, that you will not be using one size fit all. You will be using what is appropriate for that patient, even looking at the uremic heart. Whilst we are on the calcineurin, we as well as others have shown that some of the LVH which we see is mediated by the lymphocytes. It's a very, very novel way of thinking about it, that it is in fact myocardial disease, or LVH. Nobody thought would be immune mediated, but it has been demonstrated now beyond any shadow of doubt that a particular cell type, which we call CD3, in coarctation model of LVH, plays a role in fibrogenic LVH, which we see, all of us see, and that lymphocyte infiltration can be inhibited by calcineurin. And who knows that when the LV function improves post-transplantation, could that be partly because of the calcineurin which we use as immunosuppression, which will work both at myocardial specific way, as well as it may work via their effect on lymphocyte. And we now know that CD3 subtype of lymphocyte can lead to fibrogenic LVH, which is very similar to what we see in our patients. This is now a patient data. This is what the control myocardium looks like on histology. This is the LVH which you get in essential hypertension. But if you let the LVH of patients who get to CKD, you can see they're completely different. They are myocyte back-to-back. They've got still intake microvasculature. In LVH of CKD, there's a lot of fibrosis, and most of the microcirculation is shot to pieces. So it is a completely different type of LVH. It is called fibrogenic. The only other condition which you get this LVH is either you get old or in progeria. I'll come back to progeria in a while, but if you've got a 15-year-old person with progeria, and you do a myocardial biopsy, this is what it will look like. Or it will be the same if you have got a myocardial biopsy of a person who is 90-year-old. And we and others have shown that some of this is partly free radicals generation, and if you were to reverse free radical production, you can minimize, at least in preclinical models, fibrogenic component of LVH. Now come back to, again, human data, which is very sobering statistics for you guys, that if you've got an end-stage renal disease, or you've got a patient with end-stage renal disease who is in his early 20s or 30s, his cardiovascular mortality is the same as somebody in the general population who has got no CKD, and he's 85 years old. So this interpretation of this was by us, who coined the phrase that these guys have got premature aging, and we called it acquired progeria. It raised a lot of eyebrows at that time, but when you have got a controversial statement you make like that, you have to back it up. And this is progeria. You can see this is a 15-year-old progeric patients who basically showing the phenotype of a 90-year-old. Their average lifespan was 17, 18, and it has happened through an accident of nature that prelaminin, which is a protein which makes nuclear membrane quite flexible. This prelaminin A got to be processed into lamin A, which goes into the bilayer of nuclear membrane and makes it flexible so it can divide. In progeria, this prelamin A is mutated with one amino acid replacement at 1824 from cytosine to thymine, one mutation which prevents this processing of prelaminin A to lamin A. So prelamin A gets deposited in this membrane, and the nucleus cannot divide. And if the cell cannot divide, it becomes senescent. Senescent cell does not die, but it produces a lot of cytokines and other proteins which interfere with the function of the normal cells around it. Why I'm bringing progerin, which is the now prelamin A, which has not been processed, is called progerin because of the condition. We and others have shown that there is a buildup of progerin in CKD patients as well, which lead to vascular calcification. And we showed in myocardium that it is present in the nuclear membrane of myocardial cells as well. And the reason is that the enzyme which processes prelamin A to A is downregulated. So it's not a genetic disorder, it's an acquired disorder by the downregulation of the enzyme which processes, but the end result is the same, which is called progerin. I'm very excited with this new development that now we can actually measure circulating level of progerin in the plasma and assess and test this hypothesis, which we have had in preclinical model, that progerin would be high in our dialysis or CKD patient. And guess what? We have got a possible drug called lonafarnib, which is a farnesylation inhibitor, which has increased the life expectancy of these poor patients. Would be fantastic for my future PhD student to take this hypothesis forward, and hopefully we will be able over the next 3-4 years to prove this hypothesis that in fact CKD is a subclinical form of progeria, and we should be using a drug which has been approved for progeria in CKD to prevent premature aging. We have taken one step forward. This is the work of one of my other PhD student, who is now a consultant colleague of mine. We looked at the other arm of premature aging. Our cells in the body have evolved to be very eco-friendly. All the garbage which the cell makes is reutilized, including mitochondria, proteins. So all the things which a cell makes as a byproduct is reutilized. And those substrates are then used for division of that cell. And this process is called autophagy. We looked at 72 genes which are involved in autophagy flux, we call it. And you can see that in uremic heart, the whole autophagy flux was completely shot to pieces as compared to the control. And that would imply that a process which is called autophagy, which is essential for the normal health of the patient, was completely impaired in uremic, which will also give backup information, evidence that premature aging or senescence is present in CKD. I think most of you would have seen patients where they have got arteries which are like a lead pipe. They are heavily calcified, which is, by the way, phenotype of an elderly person. And we have known it since London described it in 1996, that the common carotid artery, or the big arteries in uremic patients, have got less distensibility. So they have got what you call increased pulse wave velocity. We took that into an animal model, and Raj Thorasingam, who again was my PhD student, is now a consultant colleague of mine, demonstrated in his PhD project that people with uremia or in uremic animals, there is a lot of peroxynitrite, which is basically that nitric oxide, which is essential for the normal health of the vessel, is being consumed by free radicals around, and then that lead to increased myogenic tone as well as accelerated atherosclerosis. We took another step in this direction. Is this all reversible? Tessa Savage, she was a nurse in our department, and she did a PhD with me, and she published her work and her thesis, where we reverse this increased myogenic tone, which leads to stiffening of the arteries with ACE inhibitors. And it only worked if we gave ACE inhibitors right from the beginning. If you gave ACE inhibitors at the later stage of a process, it did not work. Again, coming to my hypothesis that you need to use different medications at different stages of the condition, and one size will not fit all. We need to think outside the box and use appropriate medications at an appropriate stage of that condition. And the ACE inhibitors worked by reducing the oxidative stress. So the oxidative stress was shown by Raj, that was reversed by using ACE inhibitors right at the beginning of the animal model, which is, as you know, that ACE inhibitors can reduce NADPH oxidase-driven free radicals. We went on a fishing trip and went through the whole network of free radicals. As you can see, this is a huge review article which we did with my colleague Ravi Rajakaria, who is of Sri Lankan descent. He was my PhD student, and he is now my consultant colleague. Through his PhD, we explored the whole free radical pathway, and it became very clear that one free radical scavenger, which is scavenging superoxide, may not work if the oxidative stress is hydrogen peroxide, or if the oxidative stress is due to hypochlorite acid. So for every free radical, you need to have a different form of free radicals. Quickly, in the last 5 minutes, I may not be able to complete that. I think I've got only 5 minutes left. I will just go on and explore one other hypothesis, which is the calcium one, which I demonstrated that calcium is high in uremic animals. And this became a part of one of the 5 PhD students. I will just zoom through the remaining slide. And the slides came in was that in uremia, you've got rise in calcium, which I demonstrated to you. What does this calcium do? We propose that this calcium is the key problem for subsequent evolution of myocardial disease. Calcium would lead to hypertrophy, calcium can cause cell injury, and calcium can cause arrhythmia, and eventual outcome would be cell death or sudden death in our patient. The molecule which we chose was part of my PhD when I did it in Denver, Colorado, with Professor Shire. Bless him, he's no longer with us. He was one of the best mentors I've ever had. This is a protein called calpain, which is a housekeeping enzyme in every cell of our body, and is hugely calcium dependent. So we propose from my work that in uremic heart, calcium will go inside the cell, activate calpain, which will then degrade ankyrin. Ankyrin is a protein which keeps sodium, potassium, ATPase at the membrane. If it is cleaved off, then this will flip back into the cytosol. That as a result of this, you will get a buildup of sodium in the sodium ATPase pushes sodium out of the myocardium back into the plasma so that it can get ready for another heart cycle. This sodium buildup activates another transporter, which is called sodium calcium exchanger. So sodium by this which is now built up because of this abnormality, will be pushed out by this, but at the expense of increasing calcium. And that calcium would be, then we saw what happens to the calcium. To cut the story short, we have proven all these hypotheses through 5 PhD students of mine that calpain does get activated. You get reduced sodium potassium activity. You do get proteolysis of ankyrin and fodrin. The sodium ATPase flips back. Sodium calcium exchanger reverses and becomes sodium exporting transporter at the expense of cells. We've shown all this thing in multiple publications, and that was the most satisfying thing, that we were the first one to demonstrate that calcium overload in the cytosol, in uremic heart, in the early stages, the principal driver of what happened to that myocardium in the later stages. We are very much in the inflammation part of this. Most of us know that uremia is an inflammatory condition. It's a sterile inflammatory condition, and we have published a lot and have shown that if you have got even modest elevation of CRP at the time of kidney transplant, the higher the CRP at the time of kidney transplant, the worse the outcome were over the subsequent months. We have published again both in PNS and Journal of Immunology about the pathways, how the inflammation happened, and where the problem lies, because the resolution of inflammation doesn't happen in uremia. We have gone on through one of my PhD student who is from Nepal originally, but now is my consultant colleague, shown that in uremia, you get insulin resistance because liver becomes a corticosterone producing organ. So it basically tissue-specific Cushing's. The whole pathway was described by us. If you get Cushing's in the liver, you get gluconeogenesis, which increases the plasma glucose. but it then drives insulin production by pancreas, and you get hyperinsulinemia. So, and that has been, and this could be potentially reversible by blocking some of the enzyme, which is 11-beta-HSD1. Another PhD student of mine has shown that this gets activated even in skin, and that's why the wound healing in uremic patient is impaired, because this makes a lot of steroid in the uremic skin. That's why wound healing is so poor, and also the skin of a dialysis patient is very thin and peppery, which looks like Cushing's. So you get tissue-specific Cushing's in liver and skin, which determine some of the phenotypes which we see in our patient. Last but not least, we should not forget phosphate in our dialysis patients or in CKD, and we have shown that phosphate has always been a bigger enemy, but FGF23, which is a phosphatonin, or was the hormone produced by osteocytes, is even more better predictor of cardiovascular mortality than phosphate itself. FGF23 goes up much earlier than PTH during the course of CKD. And if you were to put FGF23 on myocardial cells, they undergo hypertrophy. So FGF23 is not only a phosphuric agent, it has got a receptor in myocardium, and through that receptor, it increases or causes LVH. The mechanism which we now know, it works through calcineurin. So FGF23 binding with this its receptor on myocardium increases the activity of calcineurin, which I showed to you earlier in my talk. So we now have got a full cycle of how calcineurin gets activated both by calcium and FGF23. And in preclinical models, it has been shown that if you block FGF3 receptor in the myocardium, which is a different receptor than the kidney, if you just block the receptor in the myocardium, you can prevent fibrosis. So the futuristic view, my friends, would be that clinical medicine will be completely different. It will be omics, AI-guided precision therapy, and we hopefully will be doing N of 1 clinical trial design. And I stop it here and welcome any questions you might have.
Thank you very much, Professor Yaqub. Your excellent presentation. It's open for discussion. Any questions from the physical audience? Yeah. Is Professor Ranga?
Professor Yaqub, excellent lecture. And I have one question. You spoke about detrimental effects of cytosolic excessive calcium levels causing cardiac damage. It's toxic to the cardiac myocytes. I just was wondering whether replacement, we commonly use calcium supplements in patients with chronic kidney disease, especially as a phosphate binder, and also we use activated vitamin D as well. So would those have any detrimental effects on cardiac myocytes by this mechanism of increasing cytosolic calcium levels?
I think it's a very excellent question. And first of all, I think you know one of my ex-registrar, Shalab, who told me that you did your training in Newcastle with him. Am I right?
That's right, Professor Yaqub, yeah.
So he sends his regards to you. Your question is very valid. Most of the calcium which I described comes from the intracellular organelles. It is not through the L channels or the T channels or the N channels by which the calcium goes. The initial calcium overload happens through the organelles. Then you get calpain activity, which is the secondary step. And then you get the reverse mode of sodium-calcium exchanger. If you were to have hypercalcemia, would that effect be more pronounced, as what you are implying, that activated calcium, vitamin Ds and calcium? We have shown it in our preclinical model, and that doesn't seem to be the case, because despite calcium going transiently high in these settings, we have got huge buffering of calcium in our bones. And there is a high turnover bone disease in uremia itself, and that is, I think, also a sort of a compensatory mechanism. So the short answer would be that it may play a role, but it's not huge. It's very tiny.
Right. Thank you, Prof.
Any more questions from?
If I just leave one message with your trainees, that please, in your future training, I think you're taking a few steps. Remember what I told you. You will learn more if you involve yourself. And by involving, you can you should spend your time with the patients and create that patient's whole life as a story for you. And you will remember it and you will learn a lot. And involving yourself is doing research. Ask questions. Don't just become obedient servants, which is the general trend, sadly, in the part of the world where we are. You should be asking questions for everything, why we are doing this. And unless you ask those probing questions, we will not be able to move the field into the futuristic direction. Don't accept anything as a dogma. Ask any question what we practice to your superiors, that why we are doing this, why can't we do this? And that will also keep me on my toes if I was your supervisor, as well as you will learn, because you will have to put a finger in my mouth for me to come out with the answers. Unless you ask the question, you will never learn. So please, if I leave anything to you guys today from my talk, I hope I've said this one thing. Please be inquisitive. Don't become just a parrot memorizing the whole textbook. Ask the question. Thank you.
Professor Yaqub, just one more question, if you that on the panel from the virtual audience. One of the nephrologists again, Dr. Nadisha, has asked, how can we optimize a uric cardiomyopathy patient for a transplant?
I don't think so that the CKD ischemia trial has shown it without any shadow of the doubt that we used to subject our CKD patients to intensive cardiovascular monitoring to the extent of doing coronary angiograms and revascularizing the hearts if that person showed coronary artery disease in an asymptomatic patient. That was the trend which I inherited when I was a junior consultant. But we needed a clinical trial that is it necessary to revascularize the heart in a stable, non-symptomatic patient before in CKD patients. And CKD ischemia trial has, I think, put that practice to bed, and we have evolved not to over-investigate our patients. The trial basically was that half of the patients in that trial with CKD got revascularized and half of the patients just got maximal medical therapy. Even with reversible ischemia, the only group of patients that didn't look at it was left main stem disease. Barring that, they included all the patients. And guess what? There was no difference in any outcomes you looked at it. Among that group of patients, quite a few people went on to get transplantation. And in even those who got transplanted, those who were in the medical arm versus interventional arm, there was no difference whatsoever in the outcome post-transplant. Yes, reversible ischemia was bad prognostic feature, so you can do all this thing to prognosticate your patient. But the main treatment for any patient would be to give them kidney transplant as soon as possible. So first of all, the cardiac phenotype doesn't progress whilst it would be on dialysis. And second thing is that there will be a huge chance of reversibility of the cardiovascular phenotype once they get a transplant in the light of normalization of renal function, normalization of calcium transients, and maybe normalization with the use of some of the drugs which we use to prevent rejection. Some of that would be in the light of what we have seen in our preclinical models, might be helping to protect the heart as well. So the treatment for any patient on dialysis is early transplantation, rather than going out of your way to use optimization of cardiovascular health, because nothing so far which we do works for optimization of cardiovascular health. the optimization of cardiovascular health in CKD is giving them a kidney transplant as soon as possible.
Thank you, Professor Yaqub. I thank you very much for joining us today as a resource person on behalf of all members of the Ceylon College of Physicians. More than your excellent presentation, I think that last words of advice to our trainees should be well taken by our trainees and something which very much we should value. Thank you very much, Professor Yaqub, for joining.
Thank you very much.
Okay, we'll be sending you a e-certificate of as appreciation. Thank you.
Thank you so much. Thank you.
And we'll be moving to next segment of our presentation today. It will be by Professor Ranga Vijayavikrama. So to introduce him, I'll again ask my co-chair to introduce.
It's a pleasure to introduce Professor Ranga Vijayavikrama, who is one of our colleagues. Professor Ranga Vijayavikrama is a professor in the Department of Clinical Medicine, Faculty of Medicine, University of Colombo, and an honorary senior consultant nephrologist at NHSL. Having obtained his primary medical qualification in 2002, he went on to pursue postgraduate studies in medicine and later in nephrology. He holds many fellowships of international scientific bodies. Professor Vijayavikrama completed his PhD in 2020 and is well known as an avid researcher. He has over 45 full research papers in peer-reviewed journals and over 40 conference papers presented at national and international fora. His topic today will be on leptospirosis and the kidney, what is new. Thank you.
Thank you, Anura, for those kind words of introduction. And also, I would like to thank the Ceylon College of Physicians for inviting me to give this talk today. So, let me just check the slides first. Yeah, okay. So the topic that I'm going to do the talk on is leptospirosis and the kidney, and whether there's anything new and what are the latest developments. So before going to that, I would like to first give the outline of my talk. So I would talk briefly on the epidemiology of leptospirosis, then talk a bit on characteristic features of AKI in leptospirosis, then moving on to pathophysiology, then a bit on identifying the disease early and how we can predict severe disease, and then on to the management, and finally a bit on leptospirosis and CKD. So when we look at the epidemiology of leptospirosis, you are all aware that it is prevalent in the tropical regions of the world, where leptospira are prevalent. So it's mainly in the tropics and the subtropics, and if you go by regions, you can see that it's present in the Central America, Latin America, and the Caribbean islands, and also when it comes to Africa, it's mainly in the sub-Saharan Eastern African countries, and in the South Asian region, it's there in Sri Lanka predominantly, as well as India, and then it's prevalent in Southeast Asian countries and also in the Oceania region. So if you look at the number of cases globally, you have about 1 million cases per year, and it's the kind of the most the most significant zoonotic disease in the world, and you have about 58,900 deaths per year. So when you look at the clinical features of leptospirosis, you know that majority of the patients don't get complications. They have a mild influenza-like illness with fever, myalgia, headache, and very non-specific symptoms, and a minority of them will develop this classic severe type of leptospirosis, which is called Weil syndrome. So roughly about 5 to 10%, and you have these complications like meningoencephalitis, acute kidney injury, pulmonary hemorrhage, acute liver failure, and the issue that we have with leptospirosis it's very difficult to predict who is going to develop complicated disease, and that is something that I'm going to answer or talk about as we go on in my presentation.
So a bit on AKI in leptospirosis. Why do we need to talk about AKI in leptospirosis? That is because AKI is common, is one of the most common manifestations of leptospirosis. Its incidence range from 10 to 87%. And also, AKI is a predictor of severe disease in leptospirosis, and so much so that stage 3 AKI is associated with 30% mortality. So if you look at the characteristic features of AKI in leptospirosis, being clinicians managing leptospirosis, we are very familiar with these features. There are certain distinct features of AKI in leptospirosis which is different to other patients with AKI. And classically, they are non-oliguric. That means you can't go by the urine output to diagnose or assess the progress of patients with AKI. And classically, they are hypokalemic, and hyperkalemia is a rare manifestation of AKI in leptospirosis. And they have various electrolyte abnormalities, including hyponatremia, hypophosphatemia, loss of magnesium, uric acid, bicarbonate, glucose in urine. So they develop a Fanconi syndrome due to the tibialopathy. And then in addition, when you look at their urine, you have pyuria, hematuria, and bile and granular cast. And classically, they have a interstitial nephritis, so they don't have much proteinuria. It's less than 1 gram per day. And when you look into the pathophysiology of AKI or pathophysiology of leptospirosis, despite the disease being around for a long time and a lot of research happening on the subject, it's not very clear how leptospirosis actually causes the complications that we know about. And when it comes to the kidney, you have the leptospira entering the body. So you have this leptospiremic phase, and then they enter the kidney and into the renal tip, through the glomerular filtrate into the renal tubules, and then one of the important receptors in the pathophysiology of leptospirosis is these toll-like receptors, which are there in the proximal tubular epithelial cells, and they recognize some of the antigenic particles of the leptospira, and then this leads to activation of an inflammatory cascade where a lot of cytokines are being produced, and this immune generation of these cytokines lead to recruitment of a lot of inflammatory cells, leading to damage to the tubular epithelial cells. So this is the kind of pathway or the process where the leptospira ultimately cause renal inflammation and renal damage. So classically, you have acute tubular interstitial nephritis in the kidney, but sometimes you can even have acute tubular necrosis. And so in addition to that, this is the direct pathway where you get damage to the kidney, but there are other indirect mechanisms where you can have toxicity to the kidney because usually in addition, in complicated patients, you have hemodynamic instability due to myocarditis, and that can lead to pre-renal and ATN as well. And then you can have hyperbilirubinemia due to liver involvement, and that can give rise to bile cast-related nephropathy. And then also you can have myositis and rhabdomyolysis leading to myoglobinuria and AKI. As I told you in the beginning, it's very difficult to predict who will develop these complications, and severity of leptospirosis-associated AKI will depend on is postulated to be dependent on two main factors. One is the disease. One is mainly the disease-related factors, the type of species causing the disease, and how much of other associated kind of clinical features they develop. And then also the patient factors, like how old the patient is, what are the other comorbidities, and the immune status of the patient. So all these, the interplay of all these factors will determine who gets a severe disease and who gets AKI. So one of the key problems that we face in managing leptospirosis in clinical practice is, especially in tropical countries like Sri Lanka, is its early diagnosis. Because you know that there are laboratory methods of diagnosis, but they take time. So I think most of the clinicians have to depend on clinical diagnosis when patients come to them. So because it's been shown that early diagnosis of the disease is associated with more vigilant treatment and prevention of further complications. So various scoring systems have been developed by clinicians over time based on the clinical features they get. And because, as you know, some other differential diagnosis when people come with fever, myalgia, and headache. These are the common symptoms of leptospirosis. This very commonly you can mistake. There are other differential diagnoses like viral fever and also dengue and malaria in some other parts of the world. So these are the common differential diagnoses that you kind of encounter in this type of situation. So there are different scoring systems, and some have been developed in Sri Lanka as well. But this is one of the latest scoring system developed by a group in Thailand, where they have used about 8 parameters: hypotension, jaundice, muscle pain, AKI, hemoglobin less than 12, a combination of low potassium and low sodium, and presence of polymorphonucleocytosis and high whites in the presence of white cell count of less than 10,000, and presence of pulmonary opacity. So they have scored each of these clinical features and developed this particular scoring system. And based on that, they have found that this is quite sensitive and a specific score. If it is more than 4, it has an area under the curve of 0.78. And they have compared this with just a standard IgM test for leptospira. And it has been shown that this clinical score is actually better than just doing a serological test with just leptospira IgM. So similarly, there are other scoring systems as well, but this is one of the more recent scoring systems that have been developed. So these are some of the things that we can adopt in our clinical practice to diagnose the disease early. Then the other problem we have is in whom that we diagnose leptospirosis, who goes on to develop severe disease. This is also important because then we can manage them in better setups. We can transfer them to places where there are ICU facilities, and we can be more vigilant with these patients, and you can intervene early. So there again, predicting severe disease is a problem over the years. And this is one of the more recent papers published in PLOS, and where they have used microRNAs. This is kind of, it's like a non-functional RNAs which has been produced in the body, and especially with the inflammatory pathway. And when you in this particular study, they have found that microRNA, this 155.5p and microRNA 630 are more in people who have got severe leptospirosis compared to milder disease. So these markers, if you look at use it as a diagnostic test or a marker of severity, they found that these can be used as markers. And also they have used these two markers, 2 microRNA molecules in different settings to assess disease severity, mortality, multi-organ failure, acute kidney injury, acute liver failure, and pulmonary hemorrhage. And all these situations, these were predictive of severe disease. So this is some of the novel molecules that have been kind of coming up in the process of predicting severe disease. Then moving on to the management of leptospirosis, especially complicated leptospirosis. So mainstay of treatment in leptospirosis is the use of antibiotics, and I'm not going to go into detail about standard or routine treatment of leptospirosis, but I'll be focusing on specific areas in the treatment. And one of the main things that we tend to rely on is renal replacement therapy, because some of them, when they develop AKI, they go on to develop fairly severe AKI needing renal replacement therapy. And this particular study, published in 2007, clearly illustrates the fact that starting renal replacement therapy early and doing more dialysis, more frequent dialysis, associated with better outcomes. So in this particular study, this is in the same center. They have, in 2 different time points, they have used 2 different strategies of dialysis for these patients. So between 2002 and 2003, they used to wait a longer period before starting dialysis, and they used every other day dialysis for these patients with AKI. Later on, they changed the policy. They started dialysis quite early, and they used daily dialysis. And what they found was people who had this kind of early dialysis and more frequent dialysis had a better outcome. So therefore, our general practice is to intervene, start dialysis early and then to do it more frequently. And when it comes to the modality, it doesn't really matter which modality you use. It's up to the availability and the experience of the clinician. And so intermittent hemodialysis, slow, low efficiency dialysis, and continuous renal replacement therapy all could be used depending on the clinical status of the patient, hemodynamic stability, and the availability and the experience. And more those days we used to use acute PD quite a lot for patients with leptospirosis, because their main problem is because of associated myocarditis. Their blood pressure sometimes can be very low, and you can't subject them to hemodialysis. And in this situation, peritoneal dialysis has been very effective, and we used to use these rigid PD catheters and do quite a lot of dialysis in the wards. But these were subsequently shown to be less effective and also associated with a lot of complications, especially infective complications, and therefore now it's gone out of practice. But now it's increasingly, clinicians are using flexible peritoneal dialysis catheters, which are usually used for chronic ambulatory peritoneal dialysis, now is used for acute dialysis, where these are cuffed catheters, which are flexible, so they don't have the same complications that you get with rigid catheters. So, and increasingly it's been used all over the world, and it's been shown to be as effective as hemodialysis. So this is something that we can think of adopting in our patients, because some of the patients that we get are not suitable for hemodialysis, and we don't have facilities to put them on CRRT because we have limited access to these treatments. So sometimes the advantage of PD is that you can put them, start them in the ward itself, and you can manage them in the ward setting, not needing to transfer them to ICUs. So this is something that we can think of in our patients. Then moving on to more specialized treatments that have been practiced in patients. This is hemoperfusion. I mean, you might have heard about cytokine filters that have been used in series with dialysis. And some of these filters can remove some of these cytokines, interleukin 6, interleukin 1, interleukin 18, TNF-alpha, and these have been used especially in the setting of sepsis, in the setting of severe sepsis, when people become hypotensive, and you have to quickly remove their inflammatory mediators. However, these are not really shown to be useful in real any trials. So we don't have any strong evidence to support these type of filters, but it has been used in severe leptospirosis, and they have reported some benefit, but we cannot advocate these for routine practice. Then one of the main questions that we have in managing leptospirosis is the use of steroids, and especially it's been shown use of oral as well as intravenous steroids, methylprednisolone as well as dexamethasone, been increasingly used by clinicians in severe leptospirosis, especially in pulmonary hemorrhage, mainly not because of its use or efficacy, but mainly because there's nothing else to do. And in some patients, they seem to have worked, and therefore there was a recent systematic review on the use of steroids in leptospirosis, but the findings of that systematic review was that majority of the evidence is based on case histories, case reports, case series, and non-randomized observational studies, and those don't give us strong evidence to support steroids. And there was only one randomized controlled trial on the use of steroids in leptospirosis, and this was this particular study where they have used desmopressin in one arm, pulse dexamethasone in another arm, and then there was a control arm. So what they found was there was no difference in any of the outcomes. Any difference in all three arms were the same. But the thing that was more worrying was that nosocomial infections were more in the steroid arm. So this conclusion of this particular trial was that the steroids are not beneficial, as well as they can cause harm. However, again, there was some methodological flaws of this particular trial, but so the final conclusion is that no recommendation can be made on the use of steroids in the treatment of severe leptospirosis with the current available evidence. Then another modality of treatment is use of plasma exchange and extracorporeal membrane oxygenation. So plasma exchange is something that had been commonly used in people with severe leptospirosis, especially when they develop lung involvement, especially when they have pulmonary hemorrhage. And as of now, there are no randomized control trials on the use of plasma exchange, and most of the data comes from case reports, case histories, and observational studies, and therefore it's very difficult to give a clear guideline on the use of plasma exchange. And increasingly, extracorporeal membrane oxygenation has been used in patients who are needing ventilation and who with lung hemorrhage, who do not have adequate oxygenation despite ventilation. And these patients are supported with ECMO, and they sometimes recover. However, again, the evidence are purely based on case reports. And the effectiveness of these two treatments are different. Like, for example, plasma exchange, the basis of plasma exchange based on the pathophysiological mechanism of the disease, where we expect the removal of some of the cytokines and antibodies helpful in the progress of the disease. Whereas ECMO is different. It's not a treatment as per se, it's just a supportive treatment for the patient to tide over the period of hypoxia. So the rationale are different, but again, the evidence is not very strong to use either of them. So as of now, we cannot give clear guidance on the use of that, but it all depends on the clinician and the clinical context where they can, and the availability of these treatments to be used in these patients. And then finally, moving on to CKD. So there's this question whether leptospirosis or leptospirosis causing AKI, can they going to develop chronic kidney disease? And this one publication from Sri Lanka sometime back, where they looked at 44 patients who had AKI in leptospirosis, and 4 of them went into develop CKD when they followed them up for 1 year. And this comes to about 9%. But when you look at the breakdown of these patients, you see that 31 patients were having AKI stage 1 and 2, and they didn't need any dialysis, they just recovered and had normal kidney function at discharge, and none of them had CKD at 1 year. And people who developed CKD were the ones who had severe AKI stage 3, out of which 11 out of 13 had impaired kidney function at discharge, and 4 of them had CKD at 1 year. So it's a group of patients who needed renal replacement therapy who had developed CKD. So it may be because they had severe AKI that they went on to develop CKD because of the impact of the severity of the AKI rather than the actual cause. So if you look at AKI, if it is very severe, irrespective of the cause, etiological agent, severe AKI needing dialysis, some of them can end up with CKD because of the severity of the damage. So it does not really tell us whether it's leptospirosis per se which has caused the CKD. Then this is another study done in Taiwan. Taiwan is another country where there's a lot of areas with where leptospirosis is endemic. And they looked at a high endemic area with leptospirosis, and they looked at, they did the serological test, microscopic agglutination test for leptospirosis, and diagnosed previous infection based on MAT of equal to or more than 100. And then they looked at the prevalence of CKD in this population, and they found that people who were serologically positive had higher prevalence of CKD in this group. So this was also suggestive of some association with the previous infection with leptospirosis can be associated with CKD. And they look at the two groups. Prevalence of CKD was higher in the group where they had previous leptospira infection. And then there's this great question whether leptospirosis is the cause for the current chronic kidney disease of unknown etiology, which is prevalent in certain regions of the world, which Sri Lanka is one. Because we know that leptospira is, if you look at the leptospira map in the world, and you look at the map of CKDU globally, they overlap, because these are both, they both occur in the same regions, Central America, South Asia, not in Southeast Asia, but definitely in these two regions where leptospira is very prevalent. So there's this question whether naturally that whether you can link leptospirosis with CKDU. And this was studied in Nicaragua, where we know it's one of the hotspots for CKDU, and they looked at serological markers of leptospirosis in these sugarcane workers. But what they found was they couldn't find any difference in CKD prevalence as they found in Taiwan in this group. They couldn't find more prevalence of CKD in the group that had previous leptospirosis infection. What they found was they looked, you know, when there is a sugarcane, when there's sugarcane farming, you have a harvesting season where so they look, this is where they are subjected to a lot of heat stress and, you know, dehydration. And they looked at acute markers of AKI in before and after the harvest in these sugarcane workers. And what they found was people who had previous leptospirosis, infection, serological evidence of infection, they had higher rise of these acute kidney injury biomarkers after the harvest. So in other words, they were more susceptible to AKI, the group who had previous leptospirosis. So these are some of the things that people have found out. Whether they're actually linking to CKDU, it's not very clear yet. And some of these are some of the hypotheses linking leptospirosis to CKDU in a summary. So either you can have leptospirosis causing AKI with inadequate clearance of the infection leading to CKD. This is one pathway. The other pathway is actually it doesn't cause AKI or kidney damage acutely, but subclinically the leptospira can remain in the kidney and lead to end-stage kidney disease. There's some evidence for this because even after infection, some people actually continue to excrete leptospira in the urine. So they can stay in the human kidney for a long period and then, can lead to some damage. These are just hypotheses, right? These are not proven. And the other hypothesis based on what has been found in Nicaragua is that, people who get infected with leptospira, although they don't get direct damage from the leptospira to the kidney, they are more susceptible to other injurious agents so that they can give rise to CKD. So in summary, leptospirosis contributes to significant morbidity and mortality in the tropics and subtropics, and AKI is associated with severe disease and leads to poor outcomes. Pathophysiology of AKI in leptospirosis is poorly understood, and early diagnosis is key to improve the management, and novel scoring systems have been developed. And predicting severe disease early is challenging, and a microRNA-based test showing early promise. And early initiation and higher dose of renal replacement therapy is associated with better outcomes. And there's inadequate evidence to recommend steroids, plasma exchange, or ECMO in the routine treatment of severe disease, right? So it's up to the clinicians to decide when and how they want to use these treatment modalities. It's just that the evidence is not strong enough for us to make any recommendations yet. And the role of leptospirosis in the development of CKD needs further evaluation. Thank you.
Thank you, Professor Ranga, for that informative and excellent presentation on some aspect of leptospirosis and kidney disease. It's open for questions from the physical audience. Any questions?
Thank you, Prof. Ranga, for that interesting lecture. I have two questions. One is, do you see any difference in patients who have, who are non-oliguric and oliguric? Is there a difference in the AKI recovery or in their outcomes-wise? Second question is regarding the steroids. So steroids are very controversial, topic when it comes to leptospirosis because we are treating with less evidence. Are there evidence to say now you were talking about the overall, the severity of the leptospirosis and the steroids. Are there evidence just on renal recovery, steroids? So for example, you give steroids and the renal recovery improves.
Yeah, so to answer the first question, so regarding
oliguric and non.
Yeah, so oliguric and non-oliguric. So what they have found, any AKI, if it is oliguric, when you compare oliguric AKI and non-oliguric AKI, the outcomes are better with non-oliguric AKIs. It is irrespective of the underlying cause. Same is with leptospirosis, because leptospirosis also studies have shown that people with leptospirosis having oliguric AKI do worse than non-oliguric. So that is the answer to that question. Why some people become oliguric and why some non-oliguric, it's difficult to explain, but maybe it's because some of them end up with more severe disease and they have different mechanisms of involved in the kidney. So because if it's a pure acute interstitial nephritis, you don't expect the urine output to drop. But when it comes to other pathways like rhabdomyolysis or maybe septic shock and going into hypertension, then the urine output may drop. So that is why they have a worse outcome. Moving on to steroids, majority of the studies which have done, even those observational studies were on steroids, were on lung hemorrhage, mainly the lung involvement. They have done. Purely for acute kidney injury, I don't think there have been any strong evidence at all or any clinical trials. And also in actual clinical practice, purely for AKI, we don't use steroids. So only when the steroid come into play when we have this very severe leptospirosis complicated with lung involvement. With the absence of any strong evidence in very severe disease of leptospirosis, I wouldn't, as a clinician, I wouldn't put people on steroids for AKI only. But when they go into develop other complications like lung hemorrhage, I think it's up to the clinician balancing out the risks versus benefit in that particular clinical scenario to whether to decide on using steroids. But current evidence does not can let us give any recommendations on that.
Thank you. The other thing is about the hemoperfusion therapy that you discussed. Basically, they are on like case-based.
Yes.
We had couple of cases that we had to use them, but they had very good outcome. I think probably have to individualize that.
Yes.
One is that it's very expensive, and it's sometimes, I mean, it will not work in every patient. Probably the patients, will have a sort of like a cytokine storm with a very severe multi-organ dysfunction. Sometimes they might work, but it has to be individualized, I think.
Yeah, and the important thing is what they recommend is if you are using these filters for leptospirosis is to use them for people with, you don't use them when they are like having normal blood pressures, or you can maintain. It's for people with pressure dropping and in that severe kind of disease.
Yeah.
So I mean, in that context, having a good response after that, using the filter is a good indicator that it may be working.
Yeah. You see within 24 hours that you see your numbers getting better, which your CRRT sometimes may not help. Just alone the CRRT.
Right.
Thank you.
I have a question now. This diagnosis of leptospirosis mainly clinical usage, no? Now the problem is some of these leptospirosis with renal things may be hantavirus.
Yeah.
So the epidemiology is also the same. We usually take the history. So it's the rodent. So how do you know whether this is actually we are dealing with hantavirus infection or leptospirosis, because it's not confirmed most of the studies.
Yeah, so what I was trying to say is not that you have to diagnose them clinically. What I was trying to say is that we have to use the serological markers to make the confirmation of the diagnosis, but it just takes time.
The studies that we done, was they have differentiated this, confirmed this?
Yes, these all trials and other studies, they have shown these differences. All are confirmed.
Sri Lankan one is also confirmed.
Yes.
Thank you.
It's just that sometimes we by waiting for these confirmatory tests, we might lose some time. So that is why these clinical scoring systems are useful until you get the serological confirmation.
Yeah, Iranga, having had a reflection on the pathophysiology you mentioned about the cytokine storm and all, would you think that immune modulation would be a new frontier of therapy in the future?
Definitely. I think that is there, and that is why these steroids have come into the picture also, because as it's not the infective phase that causes the damage, it's like the immune response to the infecting agent which is actually causing the multi-organ failure and AKI and all these problems. So naturally there is inclination to use various immunomodulatory agents to help the disease. But as of now, there is no such kind of evidence or a specific agent that is proven. But there's definitely a scope for research.
Thank you.
Professor Ranga, one more question that you brought up an interesting point about this CKDU and leptospira, the maps are overlapping. If you look at within our country, the hotspots, do they overlap?
It does, because I think if you look at the north central province, it's a hot spot for leptospirosis also. So so that region, there's a lot of leptospirosis. But again, when you look at this region, western and southern areas, we have leptospirosis, but we don't have CKDU. So it may not be, I mean, I'm not a proponent of leptospirosis being the cause for CKDU, but it's just that this is one of the hypotheses. So as for any hypothesis, these have certain supportive things as well as things against it. So if at all, if it is contributory, I don't think it's the sole cause for CKDU. It is probably one of the conditions which can make people more susceptible for some other agent causing the disease.
Thank you very much, Ranga. On behalf of the college, I would like to thank Professor Ranga Vijayavikrama for being here and presenting. And as a precision, we have a certificate of appreciation from the college. Could you please? Our next segment is a case-based discussion. So just before moving to that, I would like to thank people who have supported this event, Hema's Pharmaceutical Siders Division, and special thank to Dr. Dilushi Vijay Ratna and Dr. Dinesha Sudusingha for getting our resource person and coordinating on behalf of the college with the Sri Lanka Society for Nephrology. And from the college side, my two secretaries, Chaturika and Chamila, as well as Doctors Mayumi and Kalpana for doing all the organizing work. So next, the case discussion will be done from Kandy on as a virtual presentation by Dr. A.W.M. Vasil and Dr. K.K.A. Sandeepa. To do the formal introductions, again, I'll hand over to Anura.
Dr. Vasil, MBBS, MD, MRCP UK, is a senior consultant nephrologist at the Department of Nephrology and Transplant at the National Hospital Kandy, Sri Lanka. He is a past president of Sri Lanka Society of Nephrology. His research interests include IgA nephropathy, post-transplant infections, and PD in resource-poor settings. He was awarded President's Research Award in 2012. Dr. K.K.A. Sandeepa, MBBS MD, is a senior registrar in nephrology and transplant unit in National Hospital Kandy. He will be conducting case-based discussion on solving a puzzle of kidney injury. It's a brain teaser.
Good afternoon, everyone. So today we are going to discuss about a case of an acute kidney injury, how we investigated and how we managed it under the theme of solving the puzzle of kidney injury. So our patient is a 42-year-old male who works as a contractor in construction from Kotmale. He had no previous known comorbidities. So his initial presentation at the last week of in the last week of December with an acute febrile illness after engaging in chain cultivation in Anuradhapura 1 week back. So in addition to fever, he had loss of appetite, fatigue and headache, but his urine output was good. There were no respiratory symptoms, no bowel symptoms, no any skin rashes. So at that presentation, he was found to have stage 2 hypertension, and on investigations, there was some degree of anemia with thrombocytopenia, with renal impairment, with moderate elevation of inflammatory markers. So he was managed in hospital for about 1 week. So hemoglobin was maintaining around 9 to 8 range, and there was platelet of 80 to 8,000 on admission, which was improved on discharge to 121,000. Creatinine was 424 on admission. It was slowly coming down to 375 on discharge. So blood picture revealed normocytic normochromic anemia with thrombocytopenia, and urinalysis was reported to be normal. An ultrasound scan KUB did not reveal much changes except the increased cortical echogenicity. So he was managed as leptospirosis clinically with ceftriaxone, doxycycline, paracetamol, and for hypertension he was started on amlodipine. He did not require renal replacement therapy, and he was discharged with a plan for a week. So after 1 week of the initial hospital admission, so he presented to us with reduced urine output and feeling unwell. But at that presentation, he did not have fever, hematuria, or dysuria, no respiratory symptoms, no vomiting or diarrhea, no any headache or seizures. There was no evidence of, there was no symptoms or signs of inflammation, autoimmune connective tissue diseases like skin rash, arthralgia, oral ulcers, or alopecia. He did not have any past or family history of renal diseases. So on examination, he was failed, and he had features of fluid overload. Blood pressure was mildly elevated at 150/90. He was on amlodipine for that. There were no mucocutaneous evidence of a connective tissue disease or vasculitis. He was not icteric. There was no cardiomegaly on examination. Abdominal examination was normal, and fundus examination was also normal. So with that presentation, as a normal presentation of acute renal injury, so our main differential diagnosis at that point was rapidly progressive glomerulonephritis which could be due to several causes of glomerulonephritis. At that setting, we thought of infection-related glomerulonephritis as the first differential diagnosis, and then possible lupus nephritis and possible small vessel vasculitis. And our other differential diagnosis was acute tubular necrosis due to sepsis. So at last, we also thought of this could be a possible case of severe acute interstitial nephritis, but he was not. He was polyuric at that time. So which is usually not we don't see in acute interstitial nephritis. So with that differential diagnosis, we reviewed him with investigations. So that time WBC was in the normal range and hemoglobin was 7.7 and there was thrombocytopenia with platelet of 99,000. And inflammatory markers were only moderately elevated, ESR 35 and CRP 22. And on renal function, serum creatinine was 1049 and sodium was 136, potassium 4.7, calcium was normal, corrected calcium was normal. So urinalysis was normal with trace amount of protein, no significant pus cells with occasional red cells, no casts. Ultrasound scan KUB also did not reveal any obstruction, and the only positive change was slight increase in cortical echogenicity, but corticomedullary demarcation was intact. So when we evaluated the anemia, so reticulocyte percentage was high and LDH was 1490. There was slight increase of indirect bilirubin and AST was slightly elevated with ALT more or less normal. Coombs test was negative and coagulation profile was normal. So blood picture revealed normocytic normochromic red cells with acanthocytes and schistocytes with red cell fragments. Leukocytes were normal and there was thrombocytopenia with large platelets. So overall blood picture revealed evidence of microangiopathic hemolytic anemia with thrombocytopenia. So further investigation, septic screening was negative. The leptospira antibodies which was sent at previous admission was negative. Chest X-ray normal, ECG and echo was normal. So ANA was negative, hepatitis B surface antigen was negative, retroviral screening was negative, and C3 level was low normal with 75 and C4 level was normal. So this indicates there was some activity of the alternative complement pathway being the C3 low and normal C4. So then we proceeded with renal biopsy. So renal biopsy, so there were 30 glomuli. So one was globally sclerosed and most of the glomuli had short microvascular thrombosis within glomerular capillaries. So this long arrow indicates the thrombosis within the glomerular capillaries. And there was some fibrinoid necrosis involving the small arteries and arterioles. So this short arrow indicates the fibrinoid necrosis involving the arterioles at the vascular pole of the glomerulus. So in addition to that, there was some degree of tubulitis with tubular atrophy and interstitial fibrosis of 20%, which indicates this process has been going on for some time. And other than that, the glomeruli, there was no significant proliferative changes. A significant prominent change was microvascular thrombosis. And immunofluorescence was negative, and the overall impression was thrombotic microangiopathy with severe vascular impairment and glomerular ischemia. So with the investigations, so our patient had an acute kidney injury with microangiopathic hemolytic anemia with thrombocytopenia without significant involvement of other organs. So with that, our differential diagnosis, we had a set of differential diagnosis. With that, we thought first the complement mediated TMA as the first differential diagnosis, because this AKI with MAHA with isolated renal involvement. So in this setting, so our investigations also suggestive of some activity of the alternative complement pathway. So our first differential diagnosis was this. But we have limitations in diagnosing this because of the unavailability of the full complement assay with complement inhibitors. So the other possibility was Shiga toxin mediated HUS, but our patient did not have preceding bowel symptoms. TTP is also one of a differential diagnosis, but in TTP, isolated severe renal involvement is unlikely. There is involvement of other organs like the central nervous system. But ideally, the Adams 13 activity has to be done. So for severe hypertension is also one differential diagnosis our patient did not have. So sepsis and DIC is also our patient did not have. The coagulation profile was normal and the septic screening was negative. And the drug-induced TMA also, so most probably is the anti-cancer drugs and cotrimoxazole and the quinine. So we did not, our patient was not on any medication which can cause TMA. So autoimmune conditions, SLE, scleroderma, renal crisis, so our patient did not have and features of those and the possibility of catastrophic APLS. And the pregnancy-related conditions also can lead to this presentation. So when discussing about the management, so we initiated hemodialysis, so the indication was refractory fluid overload. And upon diagnosing the blood picture changes, we initiated plasma exchange. We did 6 cycles every other day, depending on the availability. And with that, the blood picture changes improved. But the patient remained dialysis dependent. So now it has been 3 months, patient remains dialysis dependent. And symptomatically, patient was transfused with red cells. And our long-term plan is possible of renal transplant. But the thing is, what we don't have a clear diagnosis, and if it is complement-mediated TMA, there is a possibility of high risk of recurrence in the absence of complement inhibitor therapies. So with that, so my consultant, Dr. A.W.M. Basil, will discuss about the management of thrombotic microangiopathy. This is the discussion part. So over to you, sir.
Good afternoon. I'm going to discuss this case. We have put our heading solving the puzzle. Now, when we solve a clinical problem, it's like solving a puzzle. Each piece of information is very important to arrive at a correct diagnosis. And if you overlook one particular information, it will lead to erroneous diagnosis. So when this patient presented to a base hospital in his locality, he had acute kidney injury and he had thrombocytopenia. Both of these were recognized by the treating team, but the patient also had anemia, which was overlooked by the treating team. So therefore, they could not identify the microangiopathic hemolytic anemia because they overlooked anemia. So therefore, the etiology of AKI was not diagnosed by the initial treating team. So actually, the final, when a patient had an AKI with MAHA, the usual diagnosis is AKI secondary to thrombotic microangiopathy. So because the etiology was thought to be due to leptospirosis by the initial treating team, he was discharged without referring to a renal unit, and the patient himself has to present after a week. So the patient's microangiopathy was going on for about 2-3 weeks by the time he presented to renal unit candidate. So what is the lessons we learned from this is a systematic evaluation to identify the cause of AKI is important. Not only we recognize the patient is having AKI, but also the etiology is important because most of the AKI, we give supportive therapy, but certain etiologies like RPGN or a thrombotic microangiopathy, though they are rare, they need urgent and specific treatment. So how do we evaluate a patient with elevated serum creatinine? So AKI diagnosed when the patient is having elevated serum creatinine with or without oliguria. So when a patient presents with elevated serum creatinine, you compare with the previous serum creatinine if it's available. But most often you won't have a previous creatinine unless the patient who has been following up for a chronic illness. So if the patients, if the previous creatinine is not available, all the elevated serum creatinine should be considered acute. So if a patient has elevated serum creatinine and you consider it as acute kidney injury, and traditionally we evaluate for a cause. So we divide the etiology into pre-renal, intrinsic renal disease, and post-renal disease. And intrinsic renal disease is further divided into, because if you take the nephron, there are three important compartments: the microvascular compartment, the glomerular compartment, and the tubulointerstitial compartment. The diseases involving all three compartments can give rise to AKI. So it is important to identify what is the cause of AKI. So when we evaluate, we take a history examination and we do a serum creatinine, a renal function to stage the AKI, stage 1, 2, or 3. So more importantly, we have to do the investigations to find the etiology. The three simple investigations. By doing a simple 3 investigations, we can identify the etiology to a certain extent. Those are the urine microscopy. The urine microscopy by a phase contrast will identify the sediments. And if the patient have dysmorphic red cells and red blood cell counts, that indicate an RPGN. If the patient has pus cells and pus cell counts, indicating an interstitial nephritis. If the patient has a tubular epithelial cells, it indicates an ATN. Then the next investigation is the full blood count with a blood film. Particularly when you have an anemia and thrombocytopenia, you should order a blood film to look for fragmented RBCs or cystocytes. And if you have an AKI in the presence of microangiopathy, the TMA should be considered as a differential, important main differential diagnosis. And also you had to do an urgent ultrasound scan of the KUB to look for the size of the kidneys, whether they are obstructed kidneys. So you can identify the post-renal causes by doing an ultrasound scan. So by doing, and it is important that all these 3 investigation and the renal function should be done within the first few hours, because you cannot wait too long to identify the etiology, because each and every day you wait to make a diagnosis, there will be permanent loss in GFR. And also some patients may need renal biopsy. And if when you suspect immunological disorders like SLE or vasculitis, you have to do further immunological investigations. Right. So when we apply these principles to our patient, our patient presented with AKI with thrombotic, with a microangiopathic hemolytic anemia. So any patient presenting with an microangiopathic hemolytic anemia and organ dysfunction, a thrombotic microangiopathy has to be considered as the main diagnosis. So that's how we made the diagnosis of AKI secondary thrombotic microangiopathy in this particular patient. And let's see how in general thrombotic microangiopathies are managed. So thrombotic microangiopathies are a group of disorders characterized by microangiopathic hemolytic anemia, thrombocytopenia, and a microthrombi in arterioles lead to ischemic tissue injury. The tissue injury can be in kidneys or cerebrum or heart, wherever. Though they are rare, thrombotic microangiopathies are a life-threatening condition that require urgent management. Otherwise, we may lose an organ, or even we may lose the patient. So the presenting symptoms may be non-specific depending on the organ involvement. the basic laboratory test will reveal thrombocytopenia and anemia. So on a blood film, you would see red blood cell fragmentation with evidence of hemolysis. So this is the blood picture where you can see the arrow head showing the fragmented RBC. So when you see this, it indicates it's a microangiopathic hemolytic anemia. So there are the thrombotic thrombocytopenic purpura and hemolytic uremic syndrome are primary forms of thrombotic microangiopathies. And the incidence of TTP in adults about 3 per 1 million, and the HUS also in children 3 per 100,000. Regardless of etiology, thrombotic microangiopathy is an emergency that requires a prompt treatment. In the recent years, our understanding of pathophysiology improved considerably, because initially we thought that both TTP and HUS are the same disease presenting in a different organ system, but recently we have identified the pathophysiology mechanism very correctly. Therefore, the TTP and HUS are two distinct diseases, and thrombotic thrombocytopenic purpura is caused by severe deficiency of ADAMS13 enzyme, which is a 1 milligram factor cleaving metalloprotease. The most common form of HUS, the typical HUS, following a diarrheal illness caused by Shiga toxin producing E. coli. Whereas the atypical HUS it's rare, but it's associated with abnormal host susceptibility to complement mediated damage. So how do we classify TMA? We classify TMA as primary thrombotic microangiopathy and a secondary thrombotic microangiopathy. So the primary thrombotic microangiopathy, as I mentioned, are TTP and HUS. The TTP, there are two forms. The congenital, which is rare, it's about total about 10% of all TTP is due to congenital TTP, which is due to the mutation in the gene responsible for ADAMS13. Whereas acquired TTP, which is considered about 90% of all cases of TTP are acquired form, this is due to autoantibodies against ADAMS13. The HUS, the common one is the Shiga toxin producing E. coli associated HUS. Other one is atypical HUS, which is host abnormal susceptible to complement mediated damage. In atypical HUS, in our body, there are complement alternate pathway regulating proteins like complement factor H, complement factor I, and there are many other factors. So there are genetic mutations in these factors which are responsible for atypical HUS. Unfortunately, in our country, we cannot do these tests to identify. And there are small proportion of patients have autoantibodies to complement factor H. And those patients would respond to a plasma exchange because these autoantibodies can be removed by doing plasma exchange. The secondary forms of thrombotic microangiopathies are associated with many conditions. One of the common conditions is malignant hypertension, can cause TMA. Then the pregnancy-associated thrombotic microangiopathy can manifest like preeclampsia and HELLP syndrome. And various drugs and toxins can cause secondary forms of TMA, calcineurin inhibitors, quinine, ticlodipine, and also in our country, venom-induced TMA also recognized after snake bite. Infections like influenza, HIV, EBV, and malignancies, and autoimmune diseases like SLE also can cause secondary TMA. Post-transplant, solid organ transplant and bone marrow transplant patients also can develop TMA, and DIC also can manifest like a TMA. So if you talk about thrombotic thrombocytopenia purpura, where it occurs in patients with severe ADAMS13 deficiency, where the ADAMS13 activity is less than 10%. ADAMS13 is a normal enzyme in plasma that cleaves the large forms of coagulation protein 1 Willebrand factor into small functional subunits. Acquired form of TTP is thought to be due to autoantibodies against ADAMS13, and inherited forms are due to genetic deficiency of ADAMS13. So large 1 Willebrand factor multimers bind to these endothelium and platelet-rich fibrin strands forms, which lead to intravascular hemolysis and ischemic tissue injury. So in these patients, platelet-rich fibrin thrombi forms in the microvasculature, which lead to tissue injury. The inhibitory antibodies causes the acquired disease, which is an autoantibodies to ADAMS13. The congenital TTPs, due to, as I mentioned, due to genetic mutations in gene responsible for ADAMS13, they manifest in childhood, but some patients can be normal in childhood, but they developed a TTP after a second hit. Commonly in females after pregnancy, some of these congenital TTP manifest like a HELP syndrome or postpartum renal failure. So in hemolytic uremic syndrome, it's a thrombotic microangiopathy associated with severe renal impairment. So in TTP, you don't get a severe renal impairment, but in HUS, you get a severe renal impairment. And here the ADAMS13 activity is either normal or slightly reduced. The most common form is a typical HUS associated with bloody diarrhea due to Shiga toxin producing E. coli or even Shigella also can cause. The atypical HUS is less common. It is caused by dysregulation of an alternate complement pathway, which lead to increased complement activity. So about 50 to 70% of patients with atypical HUS, we can identify genetic mutation in complement regulatory genes, whereas small subset of patients have autoantibodies against complement factor H. This is a small proportion of atypical HUS. How is the diagnosis of thrombotic microangiopathy made? So thrombocytopenia, anemia, and red cell fragmentation on the blood film is sufficient to make the diagnosis. You don't need anything else. So in a patient with organ dysfunction, if you have a blood picture suggestive of MAHA, it's enough to make a diagnosis of thrombotic microangiopathy. So finding of concomitant anemia and thrombocytopenia should prompt a request for a peripheral blood film. So when you do a full blood count, your blood count shows up anemia and thrombocytopenia, you order a blood film and ask the MLT to look for fragmented RBCs. It is very important. So that's how this particular patient's diagnosis missed in the first admission. More than 2 cystocytes per high power field or more than 1% cystocytes on a blood film is considered pathologic. So once thrombotic microangiopathy is suspected, a thorough search for a secondary cause is important to help to guide the treatment, because the secondary forms of thrombotic microangiopathy, the treatment is different. You treat the underlying disease. Whereas it's a primary form, the plasma exchange become or other complement modulatory therapy is important. So like we have to do a pregnancy test in females. We would ask the patient whether there's any drug exposure or venom exposure, HIV risk factors in HIV test, and look for other infection. And if facilities are available, do an ADAMS13 testing should be done before institution of plasma exchange therapy. However, this should not delay the treatment, right? So you draw a sample of serum, sample of blood, and separate the serum and keep for future ADAMS13 testing, and you institute therapy when you suspect TMA. And the severe ADAMS13 activity, severe loss of ADAMS13 activity that's less than 10% is indicative of TTP. So how do we manage TMA? So when you suspect thrombotic microangiopathy, so when do we suspect? When you have a patient with organ dysfunction, with anemia and thrombocytopenia and red cell fragmentation. You suspect thrombotic microangiopathy. You monitor for the end organ damage. You do a creatinine, which indicates a kidney injury, do a urine analysis, do an ECG, troponin, if there's a myocardial injury, do a head CT when the patient has confusion or neurological manifestations. And then you also start investigating for underlying diagnosis and draw a blood sample for Adams 13 testing before you start the plasma exchange therapy. So when you have a thrombotic microangiopathy and organ dysfunction, you immediately institute plasma exchange. And some patients would also require corticosteroids and folate supplementation. So how do you proceed thereafter? So if the patient's platelet count is improved after the plasma therapy, platelet more than 150,000, normalization of LDH, and symptomatically patients improve, if it is yes, you taper the plasma exchange and taper the corticosteroid if you have already started, and then the patient is in remission, but the patient needs long-term follow-up because some patients may relapse. If the patient platelet count do not increase after 3 to 5 exchanges, or if the patients have progressive symptoms, or if the patients have worsening renal functions, and if the Adams 13 is more than 10%, then you consider the secondary form of thrombotic microangiopathy and treat the underlying cause. Or you consider atypical HUS, and you have to consider eculizumab, which is a complement modulatory therapy. If the patient's platelet count has not improved in a patient who have suspected a TTP, and the patient's Adams 13 activity is low, and if the patient has not improved, it is considered a refractory TTP. You continue or intensify the plasma therapy. You start to increase the corticosteroid treatment, or you can even consider rituximab treatment, or consider additional treatment like cyclosporin or cyclophosphamide, bortezomib, or splenectomy. So this treatment also considered for relapsing disease. So when a patient has suspected thrombotic microangiopathy, you initiate plasma exchange. If the patient has improved, your diagnosis is TTP, and you arrange for long-term follow-up. And if the patient relapse, you go for a treatment like a refractory TTP. If a patient has Adams 13 less than 10%, and if the patient is not responding, you consider as a refractory TTP and consider other alternative treatments like steroids and rituximab or other treatment modalities. If the patient's Adams 13 is more than 10% in a patient with thrombotic microangiopathy, this could be either secondary form of TMA or atypical HUS. For diagnose atypical HUS, we need to have genetic testing for complement regulatory genes. So what is our conclusion? Conclusion is systematic evaluation to identify the etiology of AKI is important. So when a patient has AKI, just don't treat only the AKI, also try to identify the etiology, because some of the etiologies may need specific treatment. Presence of MAHA in a patient with AKI should raise the suspicion of TMA. And the TMA is an emergency and treatment should be initiated promptly. Thank you.
Thank you, Dr. Vasil and Dr. Sandeepa. Any questions? Anybody would like to raise anything? Okay, thank you, Vasil, for joining with us. And because because of the time restraints, we'll close the session for today. I thank the members of the Sri Lanka Society for Nephrology for joining with the Ceylon College of Physicians for this very valuable presentations today, and I hope that has enlightened all our participants. And it will be available on YouTube after some time. And so thank you very much for all the participants, and special to all the resource personnel who gave up their time to enrich this session. Thank you.
I take this opportunity to thank the College of Physicians for giving us this collaboration annually to present our CMEs with them. Thank you.